Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome back. This is Central Line, and I'm your host for today's episode, Dr. Brooke Trainer. I'm joined today with Dr. Jason Chi, the editorial board member for C, or Summaries of Emerging Evidence. Dr. Chi is going to talk to us today about a few of the very interesting items in the 41A issue. I'm really excited to jump in, but before we get started, Dr. Chi, can you introduce yourself to the audience and maybe tell us a little bit about how you became interested in the editorial board for C?
Of course. Dr. Trainer, thank you for having me. And thank you to ASA Central Line for also allowing me this opportunity to be on this podcast. So my name is Jason Chi. I am a cardiac anesthesiologist, and I live in the San Francisco Bay Area, and I work at the VA in Palo Alto. In terms of my involvement with C, I've been involved with C for over 10 years now. I actually started with them as a volunteer question writer, and I've been doing that pretty consistently for 7 or 8 years, and then moved on up to the editorial board. And I think it's a fantastic CME product that ASA offers, and it's a great way for busy practitioners to stay on top of recent advances and new technologies and new techniques in our specialty.
That's awesome. And just to get us diving in with the 41A issue, I really am interested to know about the recent item that discussed this article on how we approach patients who refuse blood transfusions because they don't want blood from donors vaccinated against COVID. Really fascinating. Can you shed some light on where this fear is coming from and why it's important for anesthesiologists to know that this is a trend?
Yeah. So the recent article was actually published in Anesthesiology, and it was first authored by Catherine Forkin, who is from University of Virginia. And it's sort of a primer for helping clinicians guide their way through how to discuss these issues with patients when patients come to them with concerns about receiving blood products from donors who have been vaccinated against COVID-19. So the background of this is that over the past few years, many practitioners and anesthesiologists have been reporting that they're encountering patients who have these concerns that they don't want blood transfusions if the blood transfusions come from donors who have been vaccinated against COVID-19. And in fact, this issue became so common that the American Red Cross and the AABB, the Association for Advancement of Blood and Biotherapeutics, they actually issued a joint statement, which was meant to reassure the public that the blood supply in the United States was safe and is safe for everybody. And what I found really interesting about this article is that I've actually personally encountered this on 2 separate occasions, including one patient in cardiac anesthesia clinic who was coming before planned cardiac surgery and stated to me that he did not want a blood transfusion because he was afraid of the remnants of the vaccine that he thought were going to be transfused to him if he received a blood transfusion. So I find that this article is very timely. I thought it was a great topic for the folks from University of Virginia to tackle. And I think it really helps clinicians to sort of walk through the steps of, hey, how do I handle this kind of a situation if I'm encountered with this as an anesthesiologist?
This is a real concern. It sounds like, patients with this fear are, it's like assimilated to them having a fear of a poison, being, poisoned from this. So I think it's important for us to talk here about the COVID vaccines. And then also, you touched upon it a little bit, but the safety of our blood transfusions. I mean, what do we know about this? What can we let our audience know about this? And then also, why should anesthesiologists care?
Yeah, so I think it's very helpful that we start with some facts. So first of all, we should just start with the basics, and we should start with the fact that the virus that causes COVID-19, which is SARS-CoV-2, it cannot be spread through blood transfusion. So point blank, just cannot be spread through blood transfusion. And the components of the COVID-19 vaccine also cannot be transmitted through the blood donations. Although, for the sake of complete thoroughness, is that the part about vaccine components not being able to be transmitted through blood transfusions has not been explicitly studied, but to the best of our scientific knowledge, we do not believe that any of the vaccine components can be transmitted through blood donations. And in 96% of the US population actually has antibodies to COVID-19, either through vaccination or immunity from exposure. The other thing is that with regards to the blood donors themselves, it is not possible to determine their vaccination status because questions about vaccination status, sex, race, religion, any of those types of questions are not required to be documented and are not asked of blood donors. So vaccination status, it's not possible to say, well, this blood has, come from someone who's vaccinated, and then this blood unit is from somebody who has not been vaccinated. That's just simply not possible. I think this is a really, really important issue for anesthesiologists because, well, for several reasons. One is that we actually transfuse blood. So we are the ones that are physically hanging blood and transfusing and checking the units. And number two, because we are the ones who do the actual blood transfusions and perform blood transfusions, we are often the people who interface with the patients to discuss blood transfusions and to make sure that the patients give their consent for blood transfusions. And in fact, that's what I do every day as a cardiac anesthesiologist. I make sure that patients are consented to receive blood and I make sure blood is available. And, since we are literally on the front lines of blood transfusions, I think this is a critical issue for anesthesiologists to be aware of and to know how to handle.
Yeah, I think, it's really interesting times that we're dealing with here. And I think it's a good point you make. We just don't know. I mean, we don't have the information on this, the status of these vaccines to be able to, relay that to our patients. And the reason we don't know is because it hasn't been determined that it is a need to know, right? I mean, we ask patients things that we need to know in order to prevent harm. And this is just not one of them that we ask patients because it's not needed to know whether it's going to harm a patient. So I think this is really important information to kind of get out there from, the science community. Are there other recommendations that can help us best manage these patients?
Yeah. And so once again, one of the great things about the article is that they actually kind of go through step by step some really concrete and practical steps that anesthesiologists can use to approach this issue with any patients that may have these sort of concerns. Some of this is going to sound, pretty obvious and, and maybe some of the listeners will say, well, hey, this is like pretty obvious stuff, but I think it's really important to reiterate. And so one of the things that the article mentions is that we as clinicians really need to approach these situations with empathy, without judgment, and really dispassionately. And we really should make an effort to try to understand why the patient has requested to refuse a blood transfusion. We should answer truthfully and respectfully. And I think that's really important. And I think, we need to set aside whatever, personal feelings we may have about this type of issue and really just focus on what the patient wants and what's driving their requests. And, I try to understand what's driving this refusal. And then the next step, of course, is after understanding is to refine strategies to deal with the refusal and then reconcile that conflict. And then, of course, developing a plan. Once again, it may seem like somewhat obvious to many practitioners, but simply by saying, you understand their concern. And that's something that a lot of patients want to hear, that they are being heard, their concerns are being respected. And regardless of what you may personally think about it, that really, really helps to build that rapport with the patient, for the patient to feel appreciated and for their viewpoints, they feel like they're being heard. And so obviously communication is really, really at the core of all this. And once again, just being empathetic, non-judgmental, and just really trying to understand where the patient is coming from. And that's where you can get off to a pretty strong start with the patient.
Okay, so we have a patient who we're, doing all we can to empathize with them. We're, really hearing them out. We feel like we've expressed as much as we can about these recommendations, but you have a patient who just continues to express hesitancy about this blood transfusion, specifically concerning vaccinated donors. So what do we do for those patients? I mean, ultimately, do we not give them a blood transfusion at all?
Right. So, hopefully not. Hopefully we don't go there. And, obviously we are always trying to act in the best interest of the patients. And so that's a, bridge, obviously, that we don't want to approach. I think there are a couple of strategies. One is to highlight the overall safety of the blood bank supply. So like we mentioned before, I always mention to the patients that the blood is screened for bacteria, viruses, fungi. And although it's not a, completely perfect process, it's pretty darn close. And statistically speaking, the chance of transmitting a virus is about 1 in 1 million, according to the best data that we have. So I think it's always good to highlight the overall safety of the blood supply. And we can start with that as a pretty strong foundation. If you frame the issue of blood refusal as a question of accepting the risk of serious harm or accepting the risk of death even, which is a highly likely outcome in the event of large volume hemorrhage, rather than the risk associated with receiving blood from a vaccinated donor. So because a lot of times the patients are very focused on the risk of the blood that's coming from the donor. So they're really focused on, well, if I get the vaccine components or the spike protein or the RNA, or they're really sort of fixed on that. But I think if you sort of reframe it as like, well, hey, there's this risk of serious harm and there's this risk of death to you, which is a very real risk. And that's a very likely outcome in the event that we can't transfuse blood to you. So it's really sort of an issue of reframing to sort of refocus the risks from abstract risks to real risks. One of the other things is that we can take some lessons from the experiences going back, decades, dealing with folks who are hesitant about receiving vaccines. It may be more helpful to educate patients about the harms of having a disease versus trying to tackle the myths and the false beliefs about the vaccines themselves. Because I think a lot of times we just get sort of caught up in these, tit for tat, that, well, there's this thing that the patient is saying, which we believe to be false. And then we sort of try to tackle that myth or that false belief. But, once again, it's sort of a reframing of the discussion. We're more taking an attack where we say, well, if you don't have the vaccine, there is this risk of getting a communicable disease. And the risk of that is very real. And the consequences of that are very real. And so I found that to be very helpful because it really brings attention to real threats versus the more abstract threats that I think the patients often present with. And, unfortunately, if a patient continues to insist on refusal of transfused blood, some patients come to us and they say, well, how about giving my own blood? So we call that, autologous donations. And this is not really sort of a cure-all for this problem because, and there are a couple of hurdles that need to be jumped over. One is that the cost of autologous blood donation may actually not be covered by insurance. And so that may depend on the insurance company and that may be either approved or not. A lot of blood bank centers actually don't handle autologous donations because they're not very common. And they actually require special procedures in terms of clerical procedures and identification and such, which are very different than handling blood that's donated from volunteers. And of course, there's the issue of physiology. You do need about 4 weeks or so or more, ideally, to allow the patient's blood volume and hemoglobin to recover. And many patients who come for surgery already have pre-existing anemia or comorbidities, so that could actually contraindicate that as well. And so I actually receive a lot of questions about autologous blood donation when patients are scheduled, for cardiac surgery. Another one is about directed donor blood. Once again, the patients can say, well, I have a family member who's willing to donate blood to me. I would feel much more comfortable receiving their blood. But once again, that is also somewhat problematic or can be problematic because there is some concern about whether the donor who's giving the blood has been either pressured to donate the blood or coerced. And so there is that sort of, lack of clarity sometimes. Donors who are related can share HLA, human leukocyte antigens, and that actually increases the risk of transfusion-associated graft versus host disease, which can be fatal, although rare, but can be fatal. And once again, with directed donors, you introduce other points of potential errors, such as transfusion error or clerical errors. There's also the time sensitivity of the donations, like how long is the blood going to be stored for, or how long can it be good? And then, of course, there's also the issue of, well, how much blood would you actually need? If we needed a large volume transfusion, would this be adequate? Because you don't want to give the patient the impression that this blood is going to be adequate for all the needs of every possibility that could happen during surgery.
So this is very interesting. We're dealing with, almost a new cohort of patients similar to our like Jehovah Witness patients, where we really do have to give perspective on the risk and benefits of blood transfusions. Before we dive into the second topic, I just ask if you could sort of zoom out and give us, a little overview, 30,000-foot view of how this article fits into the larger context of healthcare in the country.
Yeah, I think the larger context is very, very important, and it really speaks to sort of the state of affairs of healthcare in this country. I think there's a lot of things happening. There's a lot of changes. There's a lot of things that are going on. And I think, there's no denying the fact that a lot of these patients come in with this information that they've received over social media or they've received on TV. And, there's no escaping that fact that a lot of our patients are getting their information from a wide variety of sources. And a lot of social media companies, they're just abandoning efforts at fact checking. So, and that's really not helping the situation. I think we also live in a time when there's a lot of decreasing trust in traditional institutions such as science and higher education, even physicians. I think there's a lot of cynicism and, questions about the motives of healthcare institutions, perhaps even that. And some of that is actually directed at physicians as well. So, we sort of have this perfect storm of these different factors which are really working against the physician-patient relationship. And so I think it's all the more we really need to double down on doing what's best for the patient and really making sure that the patient understands that they are being heard, that their concerns are real, and we appreciate their concerns. But at the same time, we have to stick with the science and we have to stick with doing what we feel is in the best interest of the patient, because that is, what we've taken an oath to do. My suspicion is this is not going to be the one issue, sort of one and done. I think clinicians around the country are going to continue to see patients present with beliefs that are not founded and based on misinformation. And we're going to continue to see these types of things. And that's a trend.
I really like what you said about, validating these patients' concerns and hearing them out, because oftentimes that's exactly what they need. They just need to be heard, feel validated, and then be reassured. But let the science kind of guide us. And, science changes and it evolves. And I think, for us as clinicians, we need to also be sensitive to the evolving and changing science as well. So not kind of stuck in our past. So I think that's great. So a second study that I want to ask you about, it concerns a recent study that investigated measurement errors, or bias, as we call it, between the pulse oximeter measured oxygen saturation and the arterial oxygen saturation in the settings of low perfusion and hypoxemia in participants with various degrees of skin pigmentation. So first, tell us why this topic warrants this special attention.
Of course, yeah. So, like you had correctly mentioned, the topic is pulse oximetry measurement errors, or also known as bias, in patients who have darker skin pigmentation. So, what's actually interesting about this is that it's been known for many years, as far back as 1990, that pulse oximetry is prone to errors when it's used in patients who are darker skinned. And the error being that it tends to overestimate the arterial oxygen saturation. So, in plain terms, if the oxygen saturation is reading 96% on the machine, it not infrequently, the actual arterial saturation, if you were to measure it on a blood gas, would be lower than 96. So, this is an issue that's actually been known for quite a while, but it's been getting a lot of renewed attention lately. One of the things that really brought a lot of attention to this topic, once again, sort of revived it, was a study that was published in New England Journal in 2020. And that was right in the middle of the COVID pandemic. And there was a group from the University of Michigan that did this very large cohort study, several thousand patients. And they compared pulse oximetry errors for patients who were hospitalized and either self-identified as Black patients or self-identified as white. And so, once again, large cohorts, several thousand people. And they found that for patients who are self-identified Black, they had almost 3 times the frequency of occult hypoxemia that was not detected by pulse oximetry. And so the term occult hypoxemia, what that means is when the pulse oximetry on the machine measures either 92 to 96, and the actual arterial saturation on blood gas analysis reads 88 or less. So you have, once again, disparity of somewhere between 92 and 96 on the machine, and then an actual sat below 88. And so they found that that was much more frequent in patients who are self-identified Black. And so this came in the middle of the COVID pandemic, and obviously pulse oximetry was, needless to say, a very critical tool during the COVID pandemic because all the respiratory complications. And actually in 2021, a group of congressmen members sent the FDA a letter, and they asked them to review pulse oximeter devices. And actually in 2023, 2 years ago, the state attorneys general from 24 states again wrote the FDA to address these inaccuracies that are happening with pulse oximetry measurements in people who with darker toned skin. So it's received a lot of attention in the mainstream media, and interestingly enough, NBC News just covered it again, this topic, only 2 weeks ago. And so this has been getting a lot of attention. And I think this new article, which we covered in C, which was published in Anesthesia and Analgesia, it's a very, very timely article.
Yeah, I mean, how did this study shift our clinical practice, and how does it impact our clinical practice? Did FDA, has anything happened, or has anything been done about this?
Right. Yeah. So I'm going to back up a little bit. And so a little bit of background. So I think it's helpful to talk about the study. So the study is from a group from UCSF, and UCSF actually did a lot of the original studies from back in 2005 and 2007. They have a lab there where they've been looking into this issue for quite a while. So it's a study from UCSF. It's a prospective study. There was 146 volunteers, young folks who are in pretty good health. The mean age was about late 20s or so. And then what they did was they connected them to pulse oximeters and then drew arterial blood gas samples. So in the study, they actually drew almost a total of 10,000 blood samples. One of the interesting things about the study was they actually classified skin pigmentation according to something called the Fitzpatrick scale. And so that goes from a scale of 1 to 6. 1 is being the lightest pigmented, and then 6 being the darkest pigmentation. Whereas, and this is in contrast to previous studies, where previous studies used self-reported race as a surrogate. And one of the great things about this study, too, is they actually used pulse oximetry machines that are widely in use, and perhaps even in use for a lot of the listeners who are listening in on this podcast. One is made by Massimo and one is made by Nellcor. And so these are actual machines. These are not, something that's tucked away in some lab and that nobody uses, but these are actually machines that are in clinical use around the country. And what they wanted to look at was the interaction between skin pigment perfusion, like how well perfused the peripheral, extremity is, and then the degree of hypoxia. And so they wanted to see if there's any interaction between skin pigmentation, how well you're being perfused, and then how hypoxic you are. And the way they did that was they would actually create hypoxic conditions through a mouthpiece into these volunteers. And the volunteers would breathe like an air, nitrogen, and carbon dioxide mixture until they reached like a sort of a stable level of hypoxia. And then they would draw blood gases and compare the oxygen saturation from a blood gas to what was being reported at the exact same time on the machine. So in terms of sort of a methods perspective, the methodology here used is very, very excellent. It's a prospective study. They really nailed down the classifications of the skin color, and then also they used these pulse oximetry machines, which are being used in clinical practice. So methodologically, very, very sound study.
They must have used medical students to get hypoxics to convince them.
Probably, yeah.
I mean, you've explained why it matters and how it's conducted. So what's new here? What did the study find? And is it going to shift our understanding of it? Are we going to be changing things in our clinical practice?
Well, what the study found was not really surprising. What the study found was pretty consistent with what we've seen before. So 3 things. One is that the worse your perfusion, the larger the amount of error in pulse oximetry. And this is probably something that a lot of clinicians, a lot of anesthesiologists have suspected. These guys have shown, this group from UCSF, they've shown that the worse your perfusion is, the larger the amount of error in the pulse ox machine. Number 2 is that the worse your hypoxia gets, the error in the pulse oximetry machine actually gets bigger. So the lower your actual oxygen sat is, the larger the amount of error that the machine is going to give you. And once again, I should say, this is not 100% of the time. This is not like 100 out of 100 patients when they get hypoxic, there's going to be errors on the machine. That's not what I'm saying, but I'm just saying that the chances of those errors get higher, and the degree of those errors also increases. In terms of skin pigmentation, once again, no surprises here, but confirmed what the previous studies have found is that in darkly pigmented volunteer subjects with low perfusion, hypoxia gets missed a lot of times. So for one of the devices, it actually missed a diagnosis of hypoxia in up to 30% of patients. So once again, if the machine is reading between 92 to 96, and so let's say you're in the operating room and the machine is reading, say, 93. But if you have a patient who has poor perfusion and who is darker skin tone, then that reading of 94 may actually be incorrect up to 30% of the time. Up to 30% of the time, the actual set is going to be lower than 88%. And that's what this study has demonstrated. And so that's why it's so powerful, because in terms of clinical practice, this is, regardless of say, it's very important, because we don't know that the actual number that we're seeing on a pulse ox machine is the actual oxygen saturation. And so, what does this study add? It confirms the findings from previous studies that poor perfusion and skin pigmentation, these all sort of interact and conspire against an accurate diagnosis from the machines. It has a lot of implications, because we all know that pulse oximetry is used universally around the world. And so this is a potential finding that has really, really, I mean, without hyperbole, just worldwide type of implications. One of the things that this study adds is the variable of poor perfusion. And it's not just simply a matter of skin tone equals larger errors, but poor perfusion by itself, and we know there are many, many various disease states or iatrogenic causes of poor perfusion. So, peripheral vascular disease or hypothermia or use of vasopressors. These can all cause poor perfusion. But once again, this study adds that variable and says, hey, poor perfusion can actually affect the amount of error and the frequency of error of your pulse ox machine. And so as a practical clinical matter, I'd say for me in my personal practice, that may even mean I have a lower threshold to insert arterial line for cases in which I'm, sort of thinking about it, in which these variables are going to come into play in terms of poor perfusion, in terms of skin tone, that sort of thing. And then finally, I think it's a good reminder, and like you had mentioned earlier, that, science is always changing, right? And so this is a great reminder of that. It's also a reminder that machines and technology are not infallible, that just because a machine is giving you a number doesn't mean that it's, 100% accurate 100% of the time. And so I think it's a great article, and it's a little bit of a wake-up call, I think, to us as well. But it really goes to show us that we really need to stay on top of these changes because they do have clinical implications.
You know, being a critical care physician, so I work a lot in the ICUs where, I could see us looking at, these patients a little bit differently. We have our COPD patients, for example, where we tell the nurse, titrate the oxygen to 88%. But what about, our patients with darker skin pigmentation? I might actually change my clinical practice to where I'm going to, for darker skin pigmentation, raise that minimum threshold up because of how dangerous we know that, end organ perfusion is dependent on oxygen saturation and blood flow, right? So if, now that we know this and this is out there, we really should be thinking about it more. And, I just wonder, are we going to officially work to change our parameters for those low thresholds for patients with darker skin pigmentation? Maybe we have to, rely on that Fitzpatrick scale to do that. It's really interesting. So final question before I let you go. I would love to hear a bit about the work that you're doing with C. And if there's something you'd like to share with our listeners, who may not know a whole lot about the program. So if you would, just take us behind the scenes a bit to share some of your experiences with the committee.
Sure. Yeah, absolutely. C is SEE. It's an acronym which stands for Summaries of Emerging Evidence. It is a CME product for practicing clinicians, also for residents, but more directed toward practicing clinicians. It's available through the ASA, and you can receive 30 hours of CME credit every 6 months. So in one calendar year, you could receive up to 60 hours of CME credit. It's available in a paper and online format as well. It's available through the app. And the great thing about it is you can go at your own pace. You don't have to go to a conference and you don't have to travel anywhere. One of the things that's unique about C is our mission is to highlight new and emerging evidence. So what does that mean? So that means new techniques, new medications, new study findings, the application of technology such as AI. And that's been a hot topic, of course. And any kind of new findings around the world, not just in American journals, but just from journals and publications all around the world. And the C is run by an editorial board and also by ASA staff members. And the editorial board has 12 people. What we do is we review 30 different medical journals that have some kind of relevance to anesthesia. So all the major medical journals that have any kind of relevance to our field of anesthesiology, each of the editors goes through those journals literally every month and handpicks articles that we think highlight new and emerging evidence that is going to be clinically relevant for practitioners. And so this is a great way for subscribers to stay on top of the latest developments and stay on top of new developments. And we do all the work for you. The editorial board does, we pick the articles and we read them for you, we summarize them, and then we put them into a question and answer format. You don't get graded, nothing like that. But the question is merely to pique your interest. And then we have a 4 to 5, sometimes 6 paragraph discussion about a certain article. And so once again, the 2 articles that we had talked about today, the blood transfusions and then the darker skin pigmentation and plus oximetry, those are articles that were published in Anesthesiology and in ANA. And then we highlighted them in C, and we wrote a question and discussion based on those 2 articles. So just to, in summary, as C, I think it's great. I use it myself personally, even though I'm on the editorial board. I use it myself to get the CME credits because I find it to be so helpful and very interesting. I think it's a great way to stay on top of new developments, and it's a great way to get CME credits as well. So yeah, that's what C is about.
Absolutely. And Dr. Chi, thank you so much for sharing your time and your invaluable expertise with us today. I mean, I found myself just shaking my head listening to this really thoughtful discussion. And I really appreciate, I know our listeners do too, your time, your thoughtful analysis, and your ability to break down these critical issues for our listeners. It's really a pleasure to learn from you. You're so knowledgeable with all of this. So thank you so
Thank
much.
you. You're too kind. Yeah, thank you. Thank you, Dr. Trainer, for having me. And it's been a pleasure.
Yeah, absolutely. And for listeners who want to learn more about these topics or see in general, please visit us at asahq.org/SEE and come back soon for more Central Line.
You can't read everything, so C does it for you. Learn what the specialty is learning on your own time. C is available now with insights from journals from around the world. Try a sample question at asahq.org/SEE. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.